This video is all about digoxin, also known as lanoxin. Most of the time you will hear doctors and nurses call it dig. It's a cardiac glycoside, that's the chemical class, so that means how it's made up chemically. And the therapeutic class is a positive ionotrope and anti-dysrhythmic, and you'll find that there's many medications, especially cardiac medications, that have multiple therapeutic classes, so you're going to see them again and again. So when you learn about positive ionotropes, you will learn about dig. When you learn about anti-dysrhythmics, you will learn about dig. Same thing with other cardiac meds like metoprolol, for example. So that's a beta blocker, that's the chemical class. But the therapeutic classes for metoprolol are antihypertensive, anti-anginal, anti-dysrhythmic, negative ionotrope. So when you learn about antihypertensives, you will see metoprolol. When you learn about anti-anginals, you will see metoprolol. So for cardiac medications, they, of course, only have one chemical class, but there will be multiple therapeutic classes. That's why you'll see the same drugs again and again, especially when you're learning about cardiac problems. So this video is all about dig. So we know that positive ionotropes, those increase contractility. Basically, the heart squeezes harder. So we can kind of think of it as pumping more efficiently. And it's also an anti-dysrhythmic. And these medications basically try and bring the heart back into a normal rhythm or control the rate and the rhythm. So anti-dysrhythmics can decrease heart rate. They can slow down, of course, conduction. They can change how action potentials fire. So I'll just put change action potentials. Lots of different things anti-dysrhythmics can do. So those are the two therapeutic classes of dig. To understand how digoxin does these things, we have to understand what normally happens inside and outside of the cell with the movement of electrolytes. So I have drawn here a cardiac myocyte and a sodium potassium ATPase pump, and I'm going to draw another little structure here, and this is called the sodium calcium exchanger. So what's normally happening inside and outside the cells is that sodium is getting pumped outside through the sodium potassium ATPase pump, and 3 sodiums are going to come to the outside of the cell in exchange for 2 potassiums going inside the cell. So now we have more sodium outside of the cell than we do inside of the cell. And now this sodium that's outside of the cell is extremely motivated to come back in because it wants to be where there's less of it, and there's less inside the cell. And also inside the cell is negatively charged. So those forces actually, I'll circle these sodiums all together, they actually bring sodium back into the cell. All 3 of them are going to come back in. And by the name of the exchanger, you probably know what it's going to be exchanged for. You are going to get 1 calcium outside of the cell in exchange for those 2 sodiums. So just to summarize that, we have the sodium and potassium ATPase pump moving sodium outside of the cell. That electrolyte didn't want to be outside of the cell where there's a lot of it. It wanted to go back to where there's less of it. So that's a concentration gradient. And also it was attracted to the negative charge inside the cell. So through the sodium calcium exchanger, it moved back into the cell, and calcium left the cell in exchange for it. So that's what's normally happening in a cardiac myocyte. And what this means for the heart muscle is that the calcium actually moves out after each muscle contraction. So the calcium leaves the cell after the muscle contraction. Okay, so let's draw what happens if we give somebody digoxin. So this is the same cell, but now we've given the person digoxin. And we have the sodium, potassium, ATPase pump. And then our second little structure here is the sodium, calcium, exchanger? Well, when you give somebody digoxin, you can think of the digoxin as blocking this pump. It doesn't block it all the way, but it definitely slows it down. So now this sodium that normally gets pumped out using energy, normally it's 3 getting pumped out, actually builds up inside of the cell because it can't leave. Well, since it can't leave, that means there's less of it outside the cell. So I'll just put 1 little sodium outside the cell. This sodium is not as motivated to come back in through that exchanger. So this is not happening. It's not very motivated to come back in through the exchanger, which means that calcium is not going to leave the cell because it's not getting exchanged out for the sodium. You need the sodium coming in to make the calcium leave. So calcium is not leaving the cell. And that's really where the therapeutic effect of digoxin comes from. So I'm going to write that out. Calcium not leaving the cell. And again, it's because the sodium potassium ATPase pump is blocked. So we don't have as much sodium moving outside of the cell, which simply means that we don't have as much going back through the exchanger, which means that we don't have as much calcium leaving the cell. And so calcium starts to build up inside the cell. When you have more calcium inside a cardiac cell, you are going to have stronger contraction. And that's where our positive ionotropy comes from, stronger contraction. So that's just a feature of more calcium inside a cell. We could go through step by step why that happens. So the action potential travels across the cell membrane, calcium channels open, calcium gets released from the sarcoplasmic reticulum, it binds to troponin, on and on. We could get really into details, but for the purposes of this video and for NCLEX purposes, all we really have to understand is that calcium not leaving the cell leads to a stronger force of contraction. And there's going to be all sorts of effects from a stronger contraction, and let's list them here. Of course, increase contractility. And that means you are going to have increased stroke volume, which means you're going to have increased cardiac output, because let's draw out our cardiac formula here. Stroke volume times heart rate equals cardiac output. And the things that impact stroke volume are preload, afterload, and contractility. So here we have the contractility increasing, which means the stroke volume is increasing, which means the cardiac output is going to increase, which means we're going to have improved oxygen delivery. So this is one of the actions of digoxin. Doesn't let calcium leave the cell. There's another action of digoxin that we use for its therapeutic effects. So everything that we just talked about is the increasing contractility. Now let's talk about the decreasing heart rate, decreasing conduction effects of digoxin. Okay, so to understand this, we have to kind of understand the electrical conduction through the heart. So I have my SA node up here and my AV node here. So an impulse is going to start in the SA node and it's going to travel through the atrium and get to the AV node. And then the AV node is going to capture that impulse and send it down to the ventricles, and then the ventricles are going to contract. So the AV node plays a huge role in your left ventricular rate, how fast your left ventricle squeezes, which is what your heart rate is. Well, the vagus nerve that I'm going to draw in green actually modulates the AV node, which means that it can slow down impulses through the AV node. So what does digoxin have to do with any of this? Well, digoxin actually increases vagal tone. And to understand that, I'm going to zoom in on the connection between the AV node and the vagus nerve. So here we have the vagus nerve, and it's modulating the AV node. Well, we know that these parasympathetic nerves release acetylcholine. So we'll draw some little acetylcholines, and they want to bind to the receptors on, in this case, the AV node, and have an impact. And what digoxin does is it actually increases the amount of acetylcholine that's released from the vagus nerve. So of course that means more is going to bind. And digoxin also has the effect of making these receptors more responsive to acetylcholine. So digoxin doesn't force acetylcholine release like a cholinergic drug would, but it just kind of, we can imagine it as kind of supercharging this highway and then making these receptors, the muscarinic receptors that sit on the AV node, in this case M2 receptors, be more responsive to acetylcholine. So the calcium has to do with the force of contraction, and digoxin increases the amount of calcium in the cell. And digoxin also has to do with the rate of firing of the AV node. Now let's talk about some clinical uses for digoxin, and one of the number one uses you will see is in treatment of atrial fibrillation, shortened to AFib. So what happens in the normal heart, and we went through some of this already, is we have the SA node up here and the AV node here. We get a firing of the SA node, travels through the atrium. We get atrial contraction from that firing. The AV node captures the impulse, and then the left ventricle gets the impulse and the muscle responds. That's normal electrical conduction through the heart. So we'll call this number one. That's what normally happens. In atrial fibrillation, what's happening in our second step here, we have our SA node, of course, and our AV node. Now, the SA node might still be firing just fine, but one of the problems that's happening in AFib is that you get all sorts of firings from the left atrium. So the atrium just started to fire like crazy all on its own. And so now, instead of the AV node picking up in heart number one, this coordinated electrical impulse that has traveled smoothly from the SA nodes through the atrium to the AV node, is you have all these chaotic firings hitting the AV node and causing it to fire. And so you are going to get a increased ventricular rate because it's the AV node firing that makes the left ventricle squeeze. So it's picking up all these firings, these disorganized firings happening in the atrium. And then, of course, it's capturing it and making the left ventricle squeeze. So you are going to have an increased ventricular rate because the AV node is getting hit so many different times. And you'll see this is called a tachyarrhythmia. So an arrhythmia with a heart rate over 100 beats per minute. And when you have AFib, of course, you're going to have an increased ventricular rate. You are also going to have a decreased preload because you have lost the atrial kick, the smooth atrial contraction that finishes filling up the left ventricle. So decreased preload and decreased cardiac output. And just to make sure you understand that, I'm going to draw a third heart to show you what I mean by atrial kick. So of course we have a valve there. That valve opens up and it's between the left atrium and the left ventricle. This valve opens up when it's time for the left ventricle to fill up, and the left ventricle starts passively filling up. Well, it mostly passively fills up, but it's the contraction of the left atrium that fills up the last 20 to 30%, and that's called the atrial kick. And of course, we know preload is end diastolic pressure. So if we don't have as much blood in the left ventricle, we're going to have a decreased preload, and that means we're going to have a decreased cardiac output. And how does that work together? Well, stroke volume times heart rate equals cardiac output. Stroke volume is made up of preload, afterload, and contractility. If preload is decreased, stroke volume is going to be decreased. And we have another problem with cardiac output in AFib. If your heart rate, because of this increased ventricular rate, gets so fast that we have a reduced diastolic filling time, the heart just isn't in diastole long enough to really properly fill, we're also going to have a decreased heart rate. And for those reasons, AFib gives us a decreased cardiac output. And that's a big problem. We need to maintain cardiac output. So if we gave a patient digoxin in my heart number 2, I'm back looking at my heart number 2. If we gave the patient digoxin, and here we have the vagus nerve modulating that AV node, and that AV node became more responsive to the acetylcholine, and the vagus nerve started releasing more acetylcholine, this digoxin is going to decrease the heart rate, and therefore, I'll put therefore, increase cardiac output. It's not going to directly impact preload, but it is going to impact the heart rate side of things. So therefore, we could potentially get an increased cardiac output. So that's how digoxin is in treatment of atrial fibrillation. It doesn't change the chaotic firing in the left atrium. So all this chaotic firing, it doesn't treat that. It doesn't restore normal SA node control. It doesn't do anything like that, but it does act on the AV node. We also don't use it for its calcium effects when we give it for AFib. So AFib, digoxin is for the decreased ventricular rate. And that has to do with the vagus nerve. Okay, now how about a problem where we might want to use that calcium inside the cell to our benefit? Well, in that case, it's going to be heart failure. So I'll add that to our list, heart failure. We already talked about AFib, and now let's talk about heart failure. Well, there's two kinds of heart failure. There's heart failure with reduced ejection fraction. That's what that stands for, heart failure reduced ejection fraction. And then we have heart failure preserved ejection fraction. So what's ejection fraction? Well, when the left ventricle squeezes, it ejects blood, of course. And ejection fraction is the percentage of blood that actually gets squeezed out. So here we have 100% sitting in the ventricle. What gets pushed out, the percentage of that 100% is the ejection fraction. So normal ejection fraction is between 55 and 70%, meaning between 55 and 70% of what's sitting in the left ventricle gets ejected. So heart failure with reduced ejection fraction, that means that basically the left ventricle is weak, left ventricle weakness. It can't contract effectively. Blood is not ejected properly. Heart failure with preserved ejection fraction, the left ventricle is stiff, meaning it can't relax and fill up properly, which means less blood enters. there's decreased compliance. Maybe it's thickened, whatever the case might be. And we can have a normal ejection fraction, a normal percentage. So here's the heart. And let's say because my left ventricle is so stiff, it only fills up that far. And that's 100% of the volume in the heart. Well, it's not the total amount that the heart can hold. It's just 100% of what's in the heart right now. And so if you eject even 70% of that, it's still less than what the heart should be ejecting, because you don't have the total volume that you could or should have because it didn't fill up properly. So that's the difference between heart failure reduced ejection fraction and heart failure preserved ejection fraction. Both of those things, you still have poor output. So reduced cardiac output, but just for different reasons. Now, digoxin is used for heart failure with reduced ejection fraction. And you may have been able to figure out why that is already. And it's because with digoxin, you get, of course, increased contractility because of all that calcium inside the cardiac myocyte. So with heart failure, reduced ejection fraction, you have a weak squeeze, you have a decreased stroke volume, you have blood backing up into pulmonary congestion. If you give digoxin, you have increased stroke volume, increased cardiac output, and of course, less congestion over time. And that means improved symptoms, less shortness of breath, less fatigue. If you gave digoxin to somebody with heart failure with preserved ejection fraction, you have a left ventricle that couldn't fill up properly, you wouldn't really be getting any benefit because the ejection fraction is still normal. In preserved ejection fraction, the stroke volume is limited by filling, not by squeezing. So it's not really going to help, and it could actually cause harm because you're going to have an increased oxygen demand. In both of them, you're going to have an increased oxygen demand with increased contractility, but we need it for the heart failure with reduced ejection fraction. Okay, so that is how digoxin works for heart failure situations. It's going to improve contractility. Increase contractility. Which means, of course, increase cardiac output. And for AFib, we're going to have the increased cardiac output as well. And now let's talk about one of the big cautions when it comes to digoxin. Remember, it blocks the sodium-potassium ATPase pump. And let's put a little receptor on that pump. And that's where digoxin normally binds. So we'll put dig in blue. Well, what's interesting is that digoxin and potassium actually compete for this binding site. They both want to bind at that site. So when you have a high potassium, when you have hyperkalemia, you have more of a chance of potassium binding to that site, which means digoxin has less of an ability to bind. It just doesn't have as many spots. So you're going to have decreased dig effects in hyperkalemia. So I'm going to write that out. Increased potassium equals decreased dig, which of course means decreased effectiveness. Now let's take that the opposite way. We have our digoxin that, of course, wants to bind to that receptor, but we have very, very few potassiums floating around. We have hypokalemia. That means we're going to get a lot more dig binding to a lot more receptors because there's less potassium ions competing. The dig can bind more easily, more strongly. And so if we have a decreased potassium hypokalemia, we have an increased dig binding. And that means we have increased risk of toxicity. And dig is already a drug with a narrow therapeutic range, which means that the effective amount of digoxin is very, very close to the dangerous amount of digoxin. And when we push potassium problems in there, of course, we have an increased risk of toxicity if we have too low of a potassium floating around. Now, that doesn't mean people with low potassium could never or should never get digoxin, but it's just something we have to be aware of. And that brings us to digoxin toxicity. Too many digoxins on the binding sites. Toxicity. We can divide the signs and symptoms into 3 different systems. GI is the first one, nausea and vomiting, and anorexia. So complete loss of appetite. If you have a patient on DIG and they suddenly start feeling sick to their stomach and they say, I have no appetite at all, I don't feel good, think about toxicity. We have neuro signs and symptoms. And sort of a classic exam question is going to be about yellow or green vision. Another classic question for exams is halos around lights, being something that you have to watch out for on your patient with DIG. So seeing yellow halos would be digoxin toxicity until proven otherwise. And then we have the cardiac signs and symptoms. Okay, if we have too much vagal tone from all that DIG binding, you're going to have bradycardia, AV block, ventricular dysrhythmia. I'll just put VD for ventricular dysrhythmia. And digoxin toxicity can cause almost any arrhythmia. And once we get to the really life-threatening levels of digoxin, we are going to see very, very, very increased potassium in the bloodstream. And we can understand that when we review the sodium-potassium ATPase pump. So, of course, the job is to get sodium out of the cell. This is what's normally happening, and move potassium into the cell. Well, when we have so much DIG that we've totally blocked this, totally blocked it, that means that potassium that wants to get into the cell can't get in anymore. So it's building up in the serum. So that's why you're going to have hyperkalemia. The antidote for toxicity, if we have a life-threatening toxicity problem, the antidote is something called digoxin immune fab. It's given IV, and it actually binds the medication. So that's D for digoxin, and here's the immune fab, and it's going to come along and bind that, and it forms a complex called the digoxin immune fab complex, and that's excreted in the urine. Through the kidneys, you pee it out. So let's review everything that we have learned about digoxin. It's a cardiac glycoside. We give it for contractility purposes, and DIG basically means there's more calcium in the cell, which means a stronger force of contraction. And we also give it for its heart rate and conduction effects. So it has an effect on the vagus nerve, which modulates the AV node, increases vagal tone. And we can kind of think about it as our vagus nerve is firing a bit more, and the receptors in the AV node are a bit more responsive to acetylcholine. We might give this medication for atrial fibrillation or atrial flutter, heart failure, but it has to be heart failure with reduced ejection fraction. DIG has a narrow therapeutic index, and that becomes even more important when we think about its relationship with potassium. It competes for binding sites. So low potassium means increased risk of toxicity in a drug that already has a narrow therapeutic index. Some of the classic signs and symptoms of toxicity. The NCLEX loves questions about halos around lights for someone on Dig, yellow-green vision, of course, the bradycardia because of the AV node effects. There is an antidote for toxicity, and it might be given when you get into the really high potassium levels, and the high serum potassium is because of the impact on the sodium-potassium ATPase pump. Digoxin immune fab binds with Dig, forms a complex, and we excrete it in the urine. So that is an overview of digoxin.